Hello everyone. In this fourth edition of Spotters and Boosters, I shall discuss few important aspects of pharmacology based on pictorial. But before that, answers to the Spotters and the Boosters edition 3. First question was an aminoglycoside used for the treatment of amoebiasis and visceral leishmaniasis. The answer is paromycin. This is a locally acting drug, but is very effective in leishmaniasis also. Question 2 is a nitroimidazole effective against giardiasis and intra-abdominal anaerobic infections. The most commonly used nitroimidazole for such condition is metronidazole. Other could be tinidazole. It is also not the nitazoxanide, which is not at all a nitroimidazole but salicylamide. It has almost similar activity. Question 3 is an artemisinin derivative used intravenously for complicated falciparum malaria. In complicated falciparum malaria, for example, cerebral malaria, IV drug artesunate is used because it is water soluble. Question 4 is an endo-ecto antiparasitic drug used for malaria control. Ivermectin is an interesting drug. It remains in human body when taken by infected person, and when fresh mosquito bites, the ivermectin reaches into mosquito body through the sucked blood. These mosquitoes are less able to take a blood meal, and anti-malaria parasitic development is impaired in the presence of ivermectin in the mosquitoes. So it is a very unique mechanism of action to control malaria. Question 5 is a drug of choice for tropical eosinophilia. The classical drug is diethyl carbamazepine. Question 6 is a nucleoside analog used against HIV and hepatitis B. The answer is lamivudine. There could be few more, but this is most important and common drug. Question 7. A direct acting hepatitis C antiviral drug that inhibits hepatitis C viral RNA polymerase. Sofosbuvir, actually it is bound to non-structural 5A, which is a RNA polymerase in hepatitis C. Other NS5A inhibitors are also there, but they are not 5B inhibitors. That is important to understand. Question 8 is an antimalarial drug that kills hepatic hypnozoite. Most commonly used drug for radical cure is primaquine and tafenoquine. They achieve radical cure by killing the hepatic pre and extra erythrocytic forms. Question 9 is a vitamin D analog used mainly in the treatment of psoriasis is calcipotriol that suppresses keratinocytic proliferation. Question 10 last is a vitamin D analog used orally for acne vulgaris when it is extensive. Answer is isotretinoin. It corrects abdominal keratinization and reduces sebum production. We must remember it is high. Now we go with this edition 4. Spot 1 is look at the picture and the causative organism is given. Mention one drug likely to be most effective. The answer is the lesion shows folliculitis of the chain area, impetigo or psychosis barbae. The pus from this area when cultured showed staphylococcal aureus. Therefore, there are two types of the drugs available as anti-staphylococcal drugs, topical and oral. Usually for localized areas, topicals are used such as mupirocin 2%, fusidic acid 2%, and ozenoxin, that is chloroquine 1%. Most of them are applied 2 to 3 times daily. If extensive and required, oral cephalexin 250 mg 4 times daily is indicated. If MRSA is there because these staphylococcus become resistant. Then simple drugs like capsule doxycycline 100 mg twice daily or chlorotrimazole lower strength 1 twice daily can be used for 5 to 7 days. Spot 2 is what is the effect of drug X on the cardiac action potential and to which group of the drugs it belongs to. Mention one common. Now we look at the tracing, we will find that the drug X prolongs the duration of action potential and effective refractory period without affecting the rate of rise of action. These two characteristics, no change in rate of rise of action potential or phase 0, but prolongation duration means class 3 drugs according to Vaughan-Williams classification. And the most commonly used important drug extensively used is amiodarone. Beta blocker, sotalol is the only beta blocker that has class 3 action. There are pure class 3 other drugs also. Amiodarone has many other actions, but pure ibutylite, for example, is a pure drug. Spot 3 is name one drug that acts by inhibiting step X in the bacterial synthesis. Step X denotes combination of pteridine with PABA in the presence of hormone, in the presence of enzyme to form dihydrotauroic acid. And this step X is involving dihydrotauroid synthase enzyme. In simple terms, conversion of PABA to folic acid is through this step and inhibits this is a sulfonamide. That is the inhibitor of folate synthase enzyme, and in fact actually sulfonamides compete with PABA and prevent combination of PABA with pteridine residues. Thus, there is no formation of dihydrotauroic acid, which is needed for further reduction of the folic acid into folic acid later on with using another enzyme. Therefore, drug X is sulfonamide. There are many sulfonamides, usually sulfamethoxazole, sulfapyridine, sulfamethoxamine. Only use drugs. Spot 4 is one drug that inhibits step Y in malignant cells, and the step Y is involvement of dihydrofolate reductase that is needed for conversion of dihydrofolic acid into tetrahydrofolic acid, which is biologically active form of folic acid. Now, the likely drug is methotrexate. It is a folic acid analog that inhibits dihydrofolate reductase, an enzyme that rapidly converts the dihydrofolate into tetrahydrofolate. Now, its effects are seen in rapidly dividing malignant cells of hematological system. Inhibition of dihydrofolate reductase results in failure of formation of biologically active form needed for purine and DNA synthesis. Therefore, cell division suffers. We know methotrexate is used in hematological malignancies like acute lymphoblastic leukemia, non-Hodgkin lymphoma, solid organ tumors, and it is a drug of choice for choriocarcinoma 2H. Spot 5 is identify a drug that acts by inhibiting step Y in bacterial pathogens. The steps are same. However, there is a drug that has more affinity towards bacterial dihydrofolate reductase. The drug is trimethoprim, and it blocks the conversion of dihydrofolic acid to tetrahydrofolate through competitive inhibition of dihydrofolate reductase in bacteria. Why we use trimethoprim as antibacterial is because it has 50,000-fold or greater affinity for bacterial dihydrofolate reductase, and mammalian cells are relatively unaffected. Co-administration with sulfamethoxazole that produces a sequential block in the synthesis of tetrahydrofolate, and thus the combination produces synergistic supraadditive antibacterial action. Currently, sulfonamides are rarely used alone. They are always used as a combination with trimethoprim in a fixed dose combination ratio of 5:1, with that gives 20:1 serum levels of the two drugs individually, as is commonly used in the treatment of urinary tract infection, lungs infections, soft tissue infections, particularly aureus as an alternative drug, nocardia, and shigella. Co-trimoxazole is also an alternate drug for toxoplasmosis affecting vision, and here it is given along with the spot 6 is a drug which acts by inhibiting step Y in Plasmodium. Again, the steps are same. However, there is a drug that has higher affinity for malarial parasitic dihydrofolates, and there are two drugs actually. One important drug is pyrimethamine, that is a long-acting drug, and is a direct inhibitor of plasmodial dihydrofolate reductase because it has very high affinity for malarial dihydrofolate reductase than bacterial. For bacterial, trimethoprim has a greater affinity, and thus by inhibiting plasmodial dihydrofolate reductase, it reduces availability of purines needed for DNA formation. Therefore, erythrocytic schizogony suffers. The effect is slower, and when used alone, plasmonia develop mutation of the enzyme and therefore resistance develops. Therefore, it is rarely used alone. It is always used along with other anti-malarial drugs. Uh, Sulfonamide, usually a sulfadoxine, is used. Mefloquine have been used in combination, or atovaquone have been used in combination. Second drug is proguanil, that is prodrug converted into cycloguanil, and that is a dual function inhibitor of the plasmodial enzymes dihydrofolate reductase and thymidylate synthase. Thereby it inhibits plasmodial purine and pyrimidine synthesis. So answer is pyrimethamine, but it can also be pro. Spot 7 is a simple pictorial showing the effect of an anti-diabetic drug on blood glucose levels. And if you see, there is drug X that may reduce elevated fasting plasma glucose to below normal, may produce hypoglycemia. In contrast, drug Y that reduces elevated blood glucose levels but rarely causes hypoglycemia. So that there is a therefore, drug X could be any one of the sulfonylureas, glimepiride, and many glipizide, gliclazide, glyburide. It can be ripaglinide, but it has a lower likelihood of hypoglycemia. And it can be GLP-1 agonist, semaglutide, for example, but it rarely causes hypoglycemia. So answer is most probably sulfonylurea. Drug Y is an anti-hyperglycemic agent that does not cause hypoglycemia. Metformin is the most commonly used drug that doesn't cause hypoglycemia when used alone. Second drug could be pioglitazone. Now, pioglitazone also does not cause hypoglycemia when used alone. Distinctive features of metformin are metformin is not metabolized at all. It is excreted principally through kidney. Therefore, dose adjustments have to be done in renal impairment. It is not an insulin secretagogue, but it acts mainly on the liver and GIT and increases utilization peripherally, of glucose peripherally. It may cause vitamin B12 deficiency on long-term use. So they are the unique. Now homework for you. Question 1. What is the other use of primaquine apart from radical cure of malaria? Question 2. Which anti-malarial drug is also effective in toxoplasmosis and HIV/AIDS? Question 3. An anti-leprotic drug is the drug of choice against dermatitis herpetiformis, and the drug is question 4. A macrolide antibiotic used against acne vulgaris, Mycobacterium avium complex, toxocondile, and leprosy. Same drug for different indications. Question 5. Name a macrolide effective against Clostridioides difficile. What is the common characteristic among rifaximin, fidaxomicin, and neomycin? There is a simple common denominator among these three drugs. An antibacterial drug that inhibits DNA guidase 4 in gram-positive bacteria is an anti-malignant drug that acts by inhibiting topoisomerase 1 enzyme in malignant cells. Next question, anti-cancer antibiotic that inhibits topo2 function in malignant cells. And the last, a cephalosporin effective against anaerobes, bacteroides, fragilis, and some non-tubercular mycobacteria. Yes, so you can find out the answers in the standard textbooks for self-directed learning. Think over them and look at their importance. And if you want solutions, then you may attend and watch the next edition of Spotters and Boosters 5 subsequently. Thank you and good